Hello, my name is Dr. Frank McCormack. I'm the director of the Pulmonary, Critical Care, and Sleep Medicine Division at the University of Cincinnati and the scientific director of the LAM Foundation. This course will summarize LAM evidence-based practices that comprise the recently published American Thoracic Society and Japanese Respiratory Society guidelines. My LAM Clinic Director colleagues and I will discuss 8 different topics pertinent to the care of LAM patients. These include the use of HRCT, VEGF-D, and transbronchial lung biopsy in the diagnosis of LAM, the use of hormonal therapies, Doxycycline and Sirolimus in the treatment of LAM, and finally, the management of pleural disease, including pneumothorax and future lung transplant considerations. LAM is a rare systemic neoplastic disease that's associated with cystic lung destruction, chylous fluid accumulations, and abdominal tumors, including angiomyolipomas and lymphangioleiomyomas. LAM occurs almost exclusively in women, especially during childbearing years. And the disease occurs both in a sporadic form and in patients with tuberous sclerosis complex, or TSC, which is an inherited neoplastic syndrome associated with seizures, cognitive impairment, and tumor formation in multiple organs. The neoplastic cells that infiltrate the lung in patients with LAM have smooth muscle characteristics and a benign histologic appearance, arise from an unknown source, circulate in the blood and lymphatic fluids, and harbor inactivating TSC1 or TSC2 gene mutations. LAM cells also express the lymphangiogenic growth factor, vascular endothelial growth factor D, or VEGF-D, which likely facilitates access to lymphatic channels and metastatic spread.
Hello, my name is Nishant Gupta. I'm an assistant professor at the University of Cincinnati, and I'm going to talk with you guys about the role of high-resolution CT scan of the chest in the diagnosis of LAM. Let's begin by reviewing what the characteristic features of cysts look like on a high-resolution CT scan in a patient with LAM. So the classic cyst pattern in a patient with LAM will have cysts which are round, smooth, roughly uniform in size. These cysts are present bilaterally. They have a very thin wall. They are distributed in a diffuse manner with no zonal predilection, and typically the CT scan parenchyma in between the cysts appears normal on the CT scan. Here I have 2 CT scans which are showing the characteristic cyst findings in patients with LAM. On the left-hand side, you see a case of early disease where you have few cysts. I like the CT scan because it highlights all the typical features we talked about. Notice how the cysts are present on both sides of the lung. They are round, they have a thin wall, there is no septation or internal structure between the cysts, and the intervening lung parenchyma appears normal. Contrast this to the CT scan on the right, where you have a much larger preponderance of cysts. These cysts have essentially taken over the entire parenchyma, and in such advanced cases, the picture may look indistinguishable from that of someone with advanced emphysema. So let's discuss the evidence that we have explaining the performance characteristics of high-resolution CT scan in the diagnosis of LAM. The ability to accurately detect LAM based on high-resolution CT scan of the chest has been evaluated in 3 separate studies. The basic structure of all 3 studies is similar in that patients with various cystic lung diseases, the patient's CT scans were reviewed by thoracic radiologists. The radiologists were blinded to the clinical information and the ultimate diagnosis and were asked to provide the most likely diagnosis. And in one study performed by us, the reviewers also included pulmonary physicians in addition to the radiologists. This slide shows you that high-resolution CT scan is both sensitive and specific for the diagnosis of LAM. Herein we have combined the results from all 3 studies, and if you combine the data, the total number of patients with LAM in these studies were 72. The total number of patients with non-LAM cystic lung diseases was 141, and the overall sensitivity of a thoracic radiologist being able to diagnose LAM based on a HRCT review was 87%, with a specificity of 97%. So even though the sensitivity and specificity of high-resolution chest CT scan in its ability to diagnose LAM was relatively high, there are some concerns with the study design and the patients in these studies which dampen the enthusiasm for these high numbers. The major concerns relate to the issue of selection bias, where these patients were not chosen prospectively in an unselected manner. The other issue is the lack of diagnostic uncertainty, because all patients chosen in these studies had a confirmed diagnosis of LAM. This is very different from a patient that you would encounter in a clinical setting where you are unsure of the ultimate diagnosis. The third issue is the fact that not every institution has ready access to an expert thoracic radiologist. And finally, not all cases of cystic lung diseases were included in these studies. For example, there were no cases of light chain deposition disease or other metastatic tumors that one could certainly encounter in the clinical setting. So in summary, based on the concerns and issues with regard to study design and patient selection, as mentioned in the previous slide, the final recommendation that the guideline committee came up with is that we do not suggest using high-resolution chest CT scan findings as the sole confirmatory feature of LAM. And this is a conditional recommendation based on low-quality evidence. Finally, I will give you some other considerations or pearls to help with the clinical practice. Always look at the abdominal cuts of the high-resolution chest CT scan. The reason being, in a few patients, you may catch the top of the kidneys and actually identify a renal angiomyolipoma. And if so, then the combination of a renal AML and characteristic CT findings can confirm the diagnosis of LAM. In some patients, for example, patients who are asymptomatic and have a very mild cyst burden, it may be appropriate to make a probable diagnosis of LAM based on CT findings alone. This is especially true if making a definitive diagnosis will not lead to a change in management. We suggest that patients on whom you make a probable diagnosis based on CT scan findings alone be closely followed with serial pulmonary function tests done at an every 3 to 4 month interval.
Hi, I'm Lisa Young from Vanderbilt University, and today I'll be discussing the role of VEGF-D in the diagnosis of LAM. First, as a guiding principle, the diagnosis of LAM should be accomplished by the least invasive means possible. Dr. Gupta has just reviewed the ATS guideline on the use of chest CT in LAM diagnosis. Specifically, the guideline states that we suggest that HRCT alone not be used to confirm the diagnosis of LAM. While typical thin-walled cysts, as displayed here, can suggest LAM, there are many other causes of cystic lung disease in the differential diagnosis. These include pulmonary Langerhans cell histiocytosis, emphysema, Birt-Hogg-Dubé, Sjogren's syndrome with follicular bronchiolitis, amyloidosis, light chain deposition disease, and a number of others. And thus, chest CT findings alone are insufficient to confirm the diagnosis of LAM. So I will now tell you about a non-invasive biomarker which can aid in confirmation of LAM diagnosis. Vascular endothelial growth factor D, or VEGF-D, is a growth factor that induces the formation of lymphatic vessels and has a key role in tumor metastasis. It binds and activates the receptors VEGFR2 and VEGFR3. Dr. Sayama and colleagues first reported in 2006 that serum levels of VEGF-D were elevated in patients with LAM. Here is an example of data showing serum VEGF-D levels in women with LAM. In this study, all women with LAM had diagnosis confirmed either by tissue biopsy or confirmatory features of tuberous sclerosis or presence of an angiomyolipoma. In comparison, samples were studied from women proven to have other causes of lung disease based on either lung biopsy, genetic testing, or other serologies. As shown here, a line can be drawn where the majority, but certainly not all, of LAM patients have levels above the threshold of levels seen in the disease control subjects. The receiver operating characteristic curve, or ROC curve, shown here displays the excellent test performance of serum VEGF-D in distinguishing LAM from other causes of cystic lung disease. The American Thoracic Society LAM Clinical Guideline Committee performed a systematic review of the published literature on VEGF-D as a biomarker in LAM. This systematic review identified 7 studies that evaluated serum VEGF-D as a diagnostic test. In these studies, the optimal threshold for LAM discrimination varied, with most estimates falling between 600 and 800 picograms per milliliter. In pooling the results of these studies, using a threshold of 800 picograms per milliliter, the overall sensitivity was 73% across studies, with approximately 99% specificity. This slide displays the recommended interpretation of serum VEGF-D levels from a clinical laboratory that has validated the assay. First, it is critical that the starting point for this test is in women with diffuse polycystic lung disease on chest CT scan. In this context, a serum VEGF-D level of greater than 800 picograms per milliliter is considered consistent with LAM. A level of 600 to 800 picograms per milliliter is considered borderline, and the interpretation and decision-making require clinical context and consideration. Levels of less than 600 picograms per milliliter are considered normal. Of note, the median of the normal range is about 300 picograms per milliliter. And again, it's important to note that a normal VEGF-D level does not exclude the diagnosis of LAM, as some patients with biopsy-proven LAM do have normal VEGF-D levels. The ATS guideline summarized the benefits and harms of serum VEGF-D testing. For the benefits, one is that there is a low false positive rate of testing. The other is that serum VEGF-D can eliminate the need for invasive lung biopsy in patients with cystic lung disease who lack other confirmatory features. A potential harm noted, though, is that while low, there still is the potential for false positives. Here's the recommendation stated in the ATS guideline. For patients whose chest CT scan shows cystic lung disease consistent with LAM but who lack confirmatory clinical features, we suggest proceeding with serum VEGF-D testing before proceeding with invasive lung biopsy. The strength of the recommendation judged by the committee was that this was a strong recommendation based on moderate quality evidence. Now, there's been a lot of other research on VEGF-D and other potential additional roles in LAM, which I will summarize briefly here. First, there are some data indicating relationship of VEGF-D levels to some disease manifestations. Specifically, higher levels of VEGF-D are found in patients with lymphatic involvement, such as chylous effusions or ascites, or prominent axial lymphadenopathy. There are also some data indicating correlation with lung disease severity. In addition, in tuberous sclerosis complex, VEGF-D levels may discriminate women with TSC who have LAM from those who have normal chest CT scans. This data comes from cross-sectional studies and has not yet been tested prospectively. In addition, data from the MILES trial showed that VEGF-D levels may be a prognostic biomarker for lung function decline and may predict extent of treatment response to sirolimus. Lastly, VEGF-D levels decrease in patients on sirolimus or everolimus, but it's not clear whether the extent of reduction has any correlation with clinically relevant outcome measures, and more research is needed. I'll close by discussing a few additional considerations regarding serum VEGF-D testing. First, VEGF-D testing should be performed in a clinical laboratory that adheres to standards such as the College of American Pathologists Clinical Laboratory Improvement Amendments. or CAP-CLIA. Attention to sample processing is required for accurate results. Now, currently, VEGF-D testing is not widely available in commercial laboratories. There are a number of labs that offer VEGF, VEGF, or VEGF-A testing. This is different from VEGF-D and is not helpful for LAM diagnosis, so be careful when ordering this test. For information on ordering serum VEGF-D testing, please contact the LAM Foundation.
Hello, this is Nishant Gupta again, and I'm going to talk about the role of transbronchial lung biopsy in the diagnosis of LAM. Before we talk about the utility of transbronchial lung biopsy, I think it is helpful to talk about the other confirmatory features that could help establish a confirmed diagnosis of LAM without needing an invasive tissue biopsy. So the table here highlights the features that could help you get a confirmed diagnosis of LAM. To establish the diagnosis of LAM, one has to have characteristic HRCT cystic changes, plus any one of the following: elevated serum VEGF-D greater than 800, as mentioned by Dr. Young in the previous segment, the presence of tuberous sclerosis complex, the presence of renal angiomyolipomas or lymphangioleiomyomas, and both of these can be diagnosed based on radiology alone. And lastly, the presence of chylous effusions, whether pleural effusions or ascites. And remember that in greater than 70% of patients with LAM, this diagnosis can be confirmed based on one of the features above. But there will be a proportion of patients in whom all of the above mentioned features will be negative, and we have to decide about tissue confirmation. In some patients, for example, patients who are asymptomatic and patients who have a very mild cyst burden, it may be appropriate to make a probable diagnosis of LAM and do serial monitoring with pulmonary function tests. However, if you are considering prescribing pharmacological therapy for patients or treating LAM, we prefer that we have a confirmed diagnosis. Traditionally, this diagnosis has been obtained by VATS-guided lung biopsy, and that is considered the gold standard for obtaining tissue diagnosis of LAM. In this slide, I would provide a summary of all the studies we have evaluating the yield of transbronchial lung biopsy in the diagnosis of LAM. In the first study, 108 patients with LAM were reviewed from China, and 49 of these patients had a confirmed diagnosis based on transbronchial lung biopsy. However, we do not know how many patients underwent transbronchial lung biopsy for the procedure. So we do not know the exact yield nor the complication rate from this study. In another study where patients registered with the LAM Foundation answered to surveys, we found that 63 patients underwent transbronchial lung biopsy for suspected LAM, and 35 of these patients achieved a confirmed diagnosis. This amounts to a yield of 56% for transbronchial lung biopsy. Other small series have reported similar diagnostic yields. When we combined the data from all studies which reported yield, the overall diagnostic yield comes out to be 60%, with 48 out of the 81 patients who underwent transbronchial lung biopsy achieving a confirmed diagnosis. So in summary, based on the diagnostic yields as mentioned before, we suggest that in patients with suspected LAM, when a definitive diagnosis is desired and the patients have a substantial cyst burden and the diagnosis cannot be confirmed by any other non-invasive means, we suggest that a transbronchial lung biopsy be performed prior to considering a surgical lung biopsy. This is a conditional recommendation based on very low quality evidence. Some other practical considerations to help with the transbronchial lung biopsy in the clinic. It is absolutely essential that the transbronchial lung biopsy be reviewed by a pathologist who's familiar with the typical findings of LAM. In all the series mentioned below, there were quite a few cases where the diagnosis of LAM was missed on the initial transbronchial lung biopsy and was subsequently confirmed by a second review by an expert pathologist. There is also a perception amongst pulmonary physicians that doing a transbronchial lung biopsy in patients with cystic lung disease may portend a higher complication rate and risk, especially with regards to pneumothorax. The published data from the series that we have so far does not substantiate that risk, with the reported pneumothorax rate of 0 to 6%. Lastly, but not the least, this is a feature that we think plays heavily in the yield and patient selection for transbronchial lung biopsy. We believe that the underlying cyst burden plays a huge role in the ultimate diagnostic yield, to where patients with a relatively mild cyst burden may have a much lower diagnostic yield than patients with a substantial cyst burden. And on this last slide, I'm going to synthesize the diagnostic features we just talked about and provide you with a step-by-step clinical algorithm to achieve the diagnosis of LAM from the least to the most invasive manner possible. So when you evaluate a patient in clinic who has clinical features and a chest CT scan, which is characteristic of LAM, the first step should be to perform a detailed clinical examination looking for features of tuberous sclerosis complex. If your clinical evaluation confirms the presence of tuberous sclerosis complex, you have at that time a confirmed diagnosis of TSC-associated LAM. If that is not the case, the next step is to obtain a serum VEGF-D and perform a non-contrast CT scan or MRI of the abdomen and pelvis. At that time, you could also consider aspiration of a chylous fluid collection or a lymph node if present. If any of the following are present based on the above evaluations: a serum VEGF-D which is greater than or equal to 800, renal angiomyolipomas or lymphangioleiomyomas, or a positive cytology or chylous effusion, you have a confirmed diagnosis of LAM. If the diagnosis of LAM is not confirmed by any of the above means, the next question to answer is, do we need a histopathological diagnosis? And the question to answer in this circumstance is, will a confirmed diagnosis change our management? If the answer to that question is no, then it is appropriate to serially monitor this patient with pulmonary function tests done at every 3 to 4 month intervals. If, however, a tissue diagnosis is desired and or required, we suggest the next step should be lung biopsy, and we also suggest that you should consider doing a transbronchial lung biopsy prior to proceeding with a surgical lung biopsy in order to achieve a confirmed diagnosis of LAM.
This is Dr. Frank McCormick. Now I'll be talking about the role of hormonal treatment in the therapy of LAM. Symptomatic LAM occurs almost exclusively in women. Female gender restriction and worsening of LAM with pregnancy, the menstrual cycle, and estrogen-containing birth control pill use suggest hormonal influences on disease pathogenesis. Disease progression is most rapid in premenopausal women and slows after menopause. Interestingly, LAM cells express both estrogen and progesterone receptors, suggesting that they may play a role in the progression of disease. Systematic reviews have identified a multitude of studies that are able to inform the guideline review. Case reports were not considered in this analysis. Unfortunately, most studies did not report adverse events. Case series of oophorectomy, GnRH agonists, serum estrogen response modifiers, progesterone, and combination therapies have been inconclusive. We suggest not using hormonal therapy in the treatment of LAM. This is a conditional recommendation based on very low quality evidence. This recommendation places a high value on the adverse events and cost of therapy associated with hormonal treatment, and a low value on the occasional benefits supported by very low quality evidence. Additional trials are needed of hormonal agents alone or in combination with mTOR inhibitors and other therapies to determine if there's any value for hormonal therapy in the treatment of LAM. Now I'm going to be talking about the role of doxycycline in the treatment of LAM. Proteases likely contribute to cyst formation in LAM. We know that the degradation of extracellular matrix by proteolytic enzymes, such as the metalloproteinases, likely contribute to cyst formation in this disease. MMP2 and MMP9 have been found to be overexpressed in the serum of patients with LAM, as well as in the lung tissue adjacent to cystic areas in diseased lungs. Doxycycline is a tetracycline antibiotic that inhibits the production and activity of several MMPs, including MMP2 and MMP9. In our systematic review, we identified one case report, 2 uncontrolled trials, and 1 randomized trial that evaluated the effects of doxycycline in patients with LAM. Uncontrolled trials had suggested that doxycycline reduced serum and urine MMPs and was well tolerated. Effects on lung function decline were inconclusive. A single-center, randomized controlled trial detected no differences between doxycycline and placebo groups in the rate of FEV1 decline, but photosensitivity and dyspepsia were frequent side effects of doxycycline in that study. We suggest not using doxycycline in the treatment of LAM. This is a conditional recommendation based on low-quality evidence. This recommendation places a high value on the adverse events experienced by patients using a treatment that had no demonstrated benefit. Additional trials are needed to determine if combination therapies with mTOR inhibitors and other drugs may provide benefit in patients with LAM. Next, we'll talk about the role of Sirolimus in the treatment of LAM. LAM is caused by inactivating mutation in tuberous sclerosis genes, leading to loss of tuberin-hamartin protein complex function and constitutive activation of the mTOR complex. Sirolimus inhibits mTOR and restores homeostasis in cells with defective tuberous sclerosis gene function. Sirolimus shrinks tumors in tuberous sclerosis animal models, providing preclinical evidence of potential utility in patients with LAM. The multicenter international LAM efficacy of Sirolimus trial, or MILES trial, was a double-blind, randomized study in which patients with LAM and moderate lung function impairment were randomly assigned to receive Sirolimus or placebo for 12 months, followed by 12 months of observation. The treatment resulted in stabilization of lung function decline, improvement in measures of quality of life and functional performance compared with placebo. The most common adverse events were mucositis, diarrhea, nausea, hypercholesterolemia, acneiform rash, and lower extremity swelling. For patients with LAM who have abnormal or declining lung function, we recommend treatment with Sirolimus rather than observation. This is a conditional recommendation based on moderate quality evidence. The recommendation places a high value on the benefits of therapy and a lower value on adverse events. It should be noted that abnormal lung function was defined as an FEV1 less than 70% of predicted as an enrollment criteria for this study, but the average FEV1 of patients who enrolled was closer to 50% of predicted on average. For patients with LAM with symptomatic chylous fluid accumulations, we recommend treatment with Sirolimus before considering more invasive options. This is a conditional recommendation based on low-quality evidence. This recommendation places a high value on the benefits of therapy and a lower value on adverse events. Chylous fluid accumulations include chylous pleural effusions and chylous ascites. Interventions include thoracic duct ligation and pleurodesis. Indications for treatment include abnormal FEV1, rapidly declining FEV1, parameters suggesting a considerable burden of LAM, such as an elevated residual volume, a reduced diffusing capacity, or resting or exercise-induced desaturation. Other factors that may impact upon treatment decisions include premenopausal status and elevated serum VEGF-D greater than 600 picograms per mil, which have been associated with more rapid lung function decline. The rate of lung function decline slows after menopause, which may impact decisions to start or stop treatment. For the typical patient, we generally start sirolimus at 1 milligram per day and titrate up as necessary to maintain lung function stability. Most of our patients are on 1 milligram of sirolimus per day chronically. We typically measure a CBC, a renal panel, liver function tests, and lipid profile at baseline and every month for 3 months, and then every 3 months going forward. We measure trough sirolimus levels, taken right before the daily dose, monthly for 3 months, and then every 3 months. We adjust sirolimus doses downward for serum levels greater than 10 nanograms per mil, but do not titrate upwards for low serum levels if lung function is stable. We generally measure lung function every 3 months at a minimum for patients who are progressing rapidly and less frequently for patients who are slowly progressing. We advise patients to beware of common and rare adverse events, which include mouth ulcers, acne, dyspepsia, loose stools, elevated cholesterol, and lower extremity edema for the more common events, and leukopenia, hypertriglyceridemia, and pneumonitis for the rarer events. Because sirolimus therapy usually continues for prolonged periods and is associated with adverse events, we make diligent efforts to identify the lowest effective dose. Assessment of stability is based on frequent spirometry to identify trends, defined as every 3 to 6 months, depending on rapid or slow pace of progression. It can take up to a year and a half to be confident of FEV1 trajectory. Because of inherent variability, we rarely react to a single apparent drop in FEV1 with an escalation in dose. We advise patients to avoid live vaccines, direct sunlight, and interacting medications. And we consider vaccinating for shingles before starting sirolimus or during a hiatus in therapy.
Hello, my name is Charlie Strange. I work at the Medical University of South Carolina in Charleston, taking care of a number of LAM patients. When the guideline panel considered the possibilities for the questions important to the LAM community, there were 2 pleural diseases that stood out. The first of these, chylothorax, is a disorder of altered lymphatics, both in the parietal and the visceral pleura. These altered lymphatics leak a fluid that's lymphocyte-rich and exudative into the pleural space, potential space between these 2 membranes. And the failure for the fluid to egress through the parietal pleura leads to accumulation. What's been recently found is that the influence of vascular endothelial growth factor D makes these lymphatic abnormalities, and this has been particularly responsive to the effects of sirolimus after a few months in the LAM population. The more vexing problem, however, is pneumothorax, and this is the topic of our guideline. Pneumothorax, we think, occurs from subpleural cysts that grow and rupture into the pleural space. Like many rare diseases, there's a paucity of good data. Our literature search revealed 7 series and 2 observational cohorts that had evidence associated with pneumothorax and LAM that encompassed 1,591 patients. This accounted for 57% of the LAM patients in these cohorts. The more important piece, rather than the pneumothorax itself, was the very high recurrence rate that averaged nearly 70% in the majority of these series. Most of these recurrences were ipsilateral and occurred in the first year. And importantly, the number of recurrences, if you had one, ranged from 3.2 to 5.0 events. Because this is often the first manifestation of disease, we're often in the situation of not having an established diagnosis of LAM at the time of pneumothorax occurrence. Pneumothoraces usually cause pain and shortness of breath. In the observational series, 65% of individuals were treated conservatively at the first event, meaning that they did not receive any form of pleurodesis. They may have received chest tubes. We don't think this influences recurrence. In one series, the average time in the hospital was 1 month, mostly due to treatment of recurrences. Our recommendation is to suggest an ipsilateral pleurodesis following the first occurrence of pneumothorax in LAM. This is a conditional recommendation based upon the limited data, and what that implies is a need for shared decision-making between the clinicians and the patients and their families. This should be performed in a center that has expertise in pleurodesis. There was insufficient data in our observational cohorts and case series to recommend the type of therapy. The most commonly performed procedure for pleurodesis was an abrasion performed through the thoracoscope. For any recurrences, almost universally, talc was used for the second event. There is a literature on the use of abrasion plus talc that occasionally produces an acute lung injury, or ARDS. This was used in some of those individuals as well. At the time of surgery, the option for an open lung biopsy is also there to establish definitive diagnosis. We believe that should be done with a single biopsy that involves a lung cyst and should be done with someone who's done this procedure before in LAM. There are some additional considerations. This concept of shared decision-making we feel is very important in LAM. And importantly, the LAM Foundation has individuals on the telephone that can speak to your patients if there is a need for consultation of the patient experience. The trade-offs here are clear. It's the issue of the pleurodesis pain that is always seen, although handled with medications, versus the potential time spent in the hospital with having recurrences with observational therapy alone. There is no good data on whether one of these is more or less costly than the other.
In this segment, we'll be talking about lung transplant and pleurodesis. My name is Dan Dilling. I'm a LAM Clinic Director and also the Medical Director of the Lung Transplant Program at Loyola University Chicago Stritch School of Medicine. We'll begin with some background about lung transplantation for LAM. First of all, let's talk about the timing of transplantation. We think about a transplant as a good option when shortness of breath is getting worse. Oxygen is needed even at rest. Perhaps pneumothoraces are hard to control even with the use of pleurodesis. And the FEV1 on the pulmonary function test is about 30% or lower, roughly. We don't think about any of these things in isolation as a reason to need a lung transplant, but we take them together along with the patient's overall condition to determine the best timing for trying to go on the list. We should also talk about some of the complications that are specific to patients with LAM who have a lung transplant. Among them are problems in the pleural space, like a chylothorax, that can develop in the time immediately after or sometime later after the lung transplant. A pneumothorax is still a possibility, especially in a case where a patient had a single lung transplant and that native lung might be susceptible to a pneumothorax just as any person with LAM would experience. Angiomyolipomas also can be a problem because naturally they're not removed during a lung transplant procedure. They need to be monitored for enlargement, and bleeding complications can develop. And finally, there is the possibility of recurrence of LAM after a lung transplant in the new lungs. While this is very unusual, and when it's found, it is usually of minimal importance and something only seen on a routine biopsy, it is something to be aware of. That said, it almost never comes to be anything of any clinical consequence. Another segment has already gone over the topic of pneumothorax in LAM. Let me just say, though, that there are various modalities for treatment that can be utilized. We can use a tube that can be removed after the pneumothorax resolved. We can use a procedure called pleurodesis or a different procedure called pleurectomy. And there are different ways to undergo a pleurodesis. Pleurodesis is recommended with the first episode of a lung collapse or pneumothorax in LAM because it reduces the recurrence rate from 67% down to 18% according to one study. We think that this is the best approach because it results in less long-term problems with morbidity, fewer procedures down the line, and overall has been shown to have reduced costs. There are some different ways in which pleurodesis can be accomplished. We can talk about mechanical abrasion type of pleurodesis, chemical pleurodesis, with the use of a medication into the pleural space like doxycycline. We can talk about talc pleurodesis or pleurectomy. Pleurodesis can be done through a chest tube at the bedside in the hospital, or it can be done in the operating room by a surgeon through a procedure called VATS, or video-assisted thoracoscopic surgery. Nowadays, most pleurodeses are done through the VATS procedure, and it's believed that this might be the most successful way to accomplish a good pleurodesis. What are some of the concerns about pleurodesis with regards to having a lung transplant in the future? Surgeons will consistently talk about more difficulty with removing the lungs. And as we talk about this, we're not talking about trying to make life easier for the surgeon. Instead, we're trying to find the best path for the patient to accomplish a good pleurodesis and recover in the best possible way. For example, in a talc pleurodesis, the talc material can become caked into the area around the lungs, into the chest wall, and it becomes very difficult to pull away the lung tissue during the transplant operation. This means a longer surgery, and it probably means the need to go onto a bypass machine. With the use of a bypass machine comes frequently the need for blood thinners during the surgery, and all of this extra dissection of lung tissue away from the chest wall in the context of blood thinners makes for more bleeding complications. These bleeding complications can happen during and after the lung transplant surgery. Some patients, as a result, need to return to the operating room for a washout of the blood in the pleural space, sometimes more than once, and it usually results in the need for the chest tube having to stay in the patient for a longer period of time during lung transplant recovery. All of this can lead to an increased risk for early problems with lung function after the lung transplant, something we call primary graft dysfunction. It also can all result in more pain during recovery because of the need for that extra dissection around the chest wall and in the pleural space. There isn't a lot of literature about the use of pleurodesis in LAM or otherwise in patients who need to undergo a lung transplant. There are some retrospective data and survey data out there. I'll talk to you about a few of them. The first of them is a retrospective study of 14 patients with LAM who underwent pleurodesis and later lung transplant. 71% of them had extensive adhesions noted during the operation, and about half of them had significant hemorrhage afterwards or during the procedure. With that said, their data about long-term outcomes and lung function still showed better than average outcomes, suggesting that this is still a good option. Another study looked at a survey of 80 LAM patients who had undergone a lung transplant. 56% of them said that they had had a pleurodesis, most of those bilateral. 18% of patients said they had bleeding complications in the operation or afterwards, most of them, almost all of them in fact, in patients who had undergone pleurodesis. Half of those patients with the bleeding episodes needed to go back to the operating room for a second surgery to deal with those bleeding complications. Finally, a report out of Europe looking at 44 patients with LAM undergoing lung transplant demonstrated that 50% of them had a history of pleurodesis, and almost half of them had an increased bleeding during the transplant, 22% needing to go back to the operating room for bleeding. As with the earlier study that I talked about, the long-term outcomes of these patients and their lung function were still better than average, suggesting that lung transplant is still a good option for women with LAM who have had a pleurodesis. The recommendation is that history of pleurodesis should not be considered a contraindication to lung transplant in a patient with LAM. The recommendation is considered conditional because it is based upon data from case reviews rather than randomized controlled trials. It is also recommended that a patient with pleurodesis who needs to undergo a lung transplant should be referred to a center with experience in complex pleural dissection. A few additional considerations. Some centers feel a history of pleurodesis does preclude a transplant, despite this recommendation, so patients may need to be evaluated at more than one center. Because of the special needs for follow-up and proximity to the lung transplant center, This may even require consideration of relocating. Another point is that the lung transplant team may consider a single lung transplant as a way to avoid the side with the pleurodesis. It's worth saying the patients who have single lung transplants go on to have excellent outcomes with good quality of life, without shortness of breath, and without the need of oxygen, and it's often a good choice. Finally, the type of pleurodesis may come into the decision making. We talked about some of the types a little while ago, and we usually recommend that a mechanical pleurodesis should be considered as the first modality at the time of pneumothorax. This should be done through a VATS procedure with the surgeon doing a meticulous job of going over every part of the pleural surface during the operation in order to achieve the best possible results with the pleurodesis. Talc pleurodesis ought to be reserved for cases of recurrence after an initial mechanical or chemical pleurodesis. Finally, if possible, the medical team should utilize consultation and/or involvement with the local transplant surgeons at the time of pleurodesis decision-making. This engagement allows for all parties that have a stake in the future care of the patient to take ownership of the decision.
Let's summarize what we've learned about LAM in this course. In general, the diagnosis of LAM should not be based on HRCT findings alone. Serum VEGF-D can be used to make the diagnosis of LAM in women with typical cystic change on HRCT. Transbronchial lung biopsy can be used to make the diagnosis of LAM in patients with a substantial burden of cysts. Sirolimus is an effective treatment for LAM in selected patients, including those with abnormal lung function, rapid decline, or chylous effusions. And pleurodesis is recommended with the first pneumothorax in each hemithorax and is not a contraindication to future lung transplantation. The LAM Foundation has established a network of clinics that serve as a resource for patients with LAM. There are 33 domestic and 26 international LAM Foundation clinics, each headed by an experienced LAM clinician who is committed to a shared care model with referring physicians. We recommend that all LAM patients be seen in a LAM clinic at least once per year when geographically feasible. For more information about LAM clinics, providers may consult the LAM Foundation website at www.thelamfoundation.org. The LAM Foundation offers a variety of patient support services, including educational materials, information about referring providers and clinical trials, and coordination of regional meetings for LAM patients to meet and learn from one another. The Foundation sponsors annual scientific meetings that include expert clinicians, physician scientists, and patients and family members. Patients and family members are encouraged to contact the LAM Foundation to learn more about how to contribute to and benefit from progress in LAM. I'd like to thank you for participating in our ATS JRS LAM Guideline Review. I'd also like to thank our sponsors who supported this project, including the LAM Foundation, the Rare Lung Disease Consortium, and the Eshelman Institute for Innovation.
My name is Laura Bowers, and I'm a LAM patient. It took me 7 years to be correctly diagnosed with LAM. Thank you so much for participating in this program today. And our hope is that you will be able to diagnose women sooner and get them the treatment that they need. Here is my story. When I first noticed shortness of breath, it was actually when I found out I was pregnant. So I went to my doctor and I said, is this normal with pregnancy? Because I'm really having a hard time doing pretty normal everyday things. My doctor said, oh, it's completely normal to be short of breath during pregnancy, and this is just, something that'll go away.
Every woman with LAM has a story about how they came to be diagnosed, and often that story began with feeling tired while taking care of young children and working a busy job.
My shortness of breath did not go away after I had my daughter. I continued to ask my doctor about that. And they said, well, probably you need to get back into shape. So I took this as a personal challenge. I started with Bikram yoga, and then I moved on to some pretty serious workouts, but my shortness of breath never went away. And in fact, it got worse.
Most LAM patients wait about 3 to 5 years for their diagnosis because physicians generally think of the common causes of shortness of breath first, asthma and COPD.
Initially, I was diagnosed with severe asthma. I said, I really think something else is going on. And so I pushed for a CT scan. After the CT scan, they diagnosed me with severe emphysema. I was 40 years old, a non-smoker. And I said, this doesn't make sense. So that's when I got my referral to a LAM clinic.
LAM is a progressive lung disease in which the lungs are destroyed. The lungs develop emphysema-like destruction, even in a young woman who's never smoked.
It took me 7 years to be diagnosed. Right now, my lung function is about 27%. It is really frustrating to know that if I had started medicine earlier, that I would have a lot more lung function than I do now. Oh, I see a turtle! For me, living with LAM means pushing myself every day to do all the things that I want to do. I think about all of the women out there who have yet to be diagnosed, and I think about them a lot because I have walked a while in their shoes. I know the frustrations and what they face. I want doctors to know LAM. I want them to know how to diagnose it, what symptoms to look for, so that patients can get the help that they need earlier and help save their life.